This is very important article just because this highlights the difficult situations that we as interventionalists are in, and even general cardiologists, um, in terms of how to manage the dual antiplatelet therapy, which means you give aspirin and a P2Y12 inhibitor following a stent placement in patients who can present with stable heart disease and amongst patients who present with acute coronary syndrome. My name is Mandeep Singh, and I am professor of medicine in the Department of Cardiovascular Disease at Mayo Clinic in Rochester. And we are publishing a very important article in the Mayo Clinic Proceedings that's upcoming, which deals with relevance of high bleeding risk and post-discharge bleeding among patients undergoing percutaneous coronary intervention. The the high overview of this article is summed up in one sentence, that is, one size does not fit all. And we have then in this review article dissected those subgroups, which are then easy for the readers to comprehend, assess, and then apply these recommendations into their general clinical practice. The dual antiplatelet therapy in this article then is divided into different categories of patients who are presenting with stable heart disease, patients who are presenting with acute coronary syndrome, and more importantly, patients who have atrial fibrillation and then need antithrombotic therapy after a stent is placed. We at Mayo Clinic are at the forefront in terms of not only adopting the current guidelines, but also following these patients up rigorously so that we can know whether the new recommendations are right or wrong for the patient, and then further change our management strategies. Previously, there was just one set of recommendations published in 2016 by Levine and colleagues. So those are the ACC AHA recommendations. From that 2016 recommendations, in the last almost 9 years, significant progress has been made in terms of not only changing the P2Y12 inhibitors from clopidogrel to ticagrelor or prasugrel in patients with acute coronary syndrome, based on the results of the Plato trial and the trials that dealt with the prasugrel. But also then we um, uh, adopted guidelines based on the more recent trials, which then looked into a combination of ticagrelor with aspirin, for example, the Twilight trial. So, what is happening more recently is that we have shied away from just giving clopidogrel and aspirin to all comers to giving clopidogrel only to patients with stable heart disease, and then giving ticagrelor and prasugrel to patients with acute coronary syndrome. Now, what has happened also is now we have started to use models which then determine patients' bleeding risk. So there were two models. One is the ARC-HBR model that we highlighted in this review, and the other one is the precise DAPT score. So we challenge the readers to use those models to calculate the bleeding risk of the patient, because that has a direct implications to their clinical practice. So for example, if patient has high bleeding risk as determined by either of these models, then one should start thinking about shortening the duration of dual antiplatelet therapy From 12 months that is currently recommended to 6 months, now the latest consensus statements that we have highlighted in our review article, the high bleeding risk patients, acute coronary syndrome, you just can't give and get by 1 month of dual antiplatelet therapy, and then you can follow it up just with ticagrelor for 12 months. So that's a significant advance from what we used to do even less than 10 years ago. Similarly, we have expanded on the recommendations amongst patients who have atrial fibrillation and need antithrombotic therapy. And those are important too because these patients are on oral anticoagulants, putting them at a very high bleeding risk over time. But then when you add clopidogrel or ticagrelor, which is needed to prevent stent thrombosis, further increases their bleeding risk. So how to manage that is detailed in a review article. So from a patient's perspective, patients need to know that if they have a stent placement, then the decision is based on whether they presented with stable heart disease as an outpatient or they presented as an inpatient with a ST elevation myocardial infarction or non-ST elevation myocardial infarction, putting them at a higher ischemic risk. So that is the first determinant of the duration of antiplatelet therapy. And the second uh, uh, point, which is important in their management strategy, is, as I mentioned before, their bleeding risk. Once we know this patient has acute coronary syndrome and they have high bleeding risk, then we will definitely err on the side of not only shortening their duration of dual antiplatelet therapy, or we can de escalate. So, de escalation meaning we can then lower the intensity of P2Y12 therapy from prasugrel, ticagrelor, which are the newer P2Y12 inhibitors, to clopidogrel. And that has been shown in some of the trials that have used platelet functions or genetic polymorphisms to then help with the decision making process. The, uh, the next steps for our research continue to evolve. Strategies, I think, will unfold in the next few years as we not only grapple with the complexity that the patients present with nowadays, older patients, patients with multimorbidity who have bled in the past. How do you manage these patients? In the future, we will seek aid from pulmonary function test, genotyping. There are newer P2Y12 inhibitors that are becoming available, so those will be tested. And so all these things will come up in the next 1 to 2 years that will further modify our strategies in terms of abbreviating the duration of dual antiplatelet therapy and then de escalating that therapy. Thank you.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.